going to be talking about healthy aging. And as I thought about it, I thought, what would I tell you that would be kind of fun and lively and create the dynamic for all of us to keep a conversation going. So let's start by thinking a little bit about the progress in longevity that's gone on, and what about it. So, but at the turn of the century, the average lifespan was 47 years of age, and now we know that our lifespan is about 80, and most of us are living well past that. So lifespan is exciting, longer. Many are. We say that 80. We say that 80 is the new 60, 60 is the new 40, and that's our story, and we're sticking to it. That's right. In 2020, about 20% of the population will be over 65. And we see that where there used to be a rectangle, there used to be a pyramid to our aging with the younger people at the bottom and the older people at the top. We now see the rectangularization of aging. And with that comes a lot of complexity around caregiving and care needs and who in the family unit is responsible for what. But it's a great celebration in this country and in the world to think about the ways that we have progressed in longevity. That also means 70 million older adults. And so that means that we need to be anticipating that age wave tsunami that we talk about, and how we will all be ready for successful aging and making sure that we have a workforce for that group as well. Well, are we ready? I'd like to think so. And some of the upcoming answers will come through in the breakthroughs in technology, I do believe. So how many of you use a cell phone? Raise your hand. Look at that. And how many of you use an app on your cell phone? And how many of you use an app for your health care on your cell phone? So in the next wave, if I were to meet you a year from now, I bet you'd all be telling me about apps on your cell phone. So let's talk about that a little bit as well. I'd like to also talk about the amazing progress that has gone on, the great progress in this world around what has kept us aging successfully. Well, antibiotics. It used to be that people died of infectious disease. With the advent of antibiotics in the 30s, all of a sudden a whole change occurred. Pneumonia used to be called the old person's best friend, and that is absolutely not the case. I see some of you nodding, where the treatments have just accelerated beyond our wildest imagination. Pacemakers. There were not pacemakers before like the 40s, and so in the absence of pacemakers, if you had asystole, that was a problem. And if your heart rate went into first degree or second degree or third degree heart block, that would be a serious problem. But pacemakers are another example of the extraordinary technology and miracles, really. Renal dialysis. Well, prior to that, one died of kidney failure, but now with renal dialysis, and an interesting young man I met recently from Sweden has started a whole a movement in that country where what he did, his name is Sven Jennison, is he said, I'm a dialysis patient, but I don't want you to help me with my dialysis. I want a key to the dialysis room, and I will take care of it myself. And he does. And so that whole structure has changed with self-care, self-management. We'll talk about that a little bit too, one of our signature areas in Bouvé. So the point is that the technology is accelerating, and prior, if you had a person with a heart attack, we waited until the heart stopped. And then we resuscitated you. Now we anticipate that instead, which is good. Dual demand pacemakers, and I love this statistic. Last year in America, there were 700,000 knee replacements, 350,000 hips. You're all going to be bionic. We can replace anything. We can do stem cell research, and I'm kidding, not much with what's possible. And so we know that the strategies change. And I thought to myself, instead of drilling down on the usual suspects, which I might talk about in terms of clusters of topics, let's do it this way. Today I'm going to do Dean Fulmer's book club. Is that all right with you? Okay, so I'm filling in for Oprah here as we do Dean Fulmer's book club, and what I want to do is use this book club as an approach to discussing healthy aging, and full disclosure, I'm picking my favorite authors, okay? So I'd like to point out the first book, and this is a book by Robert Neal Butler. He was the founding director of the National Institute on Aging in 1975, and he wrote a Pulitzer Prize-winning book called Why Survive Being Old in America. Bob was extraordinary, and he laid it out in ways that were just so compelling. This book was a game changer, and so he wrote the book, opened the National Institute on Aging, and he won the Pulitzer Prize. So he was the person who said, what are the myths of aging? myths, and he refuted each of them in this book. It came out in a second edition about 5 years before he died, which was about 5 years ago, and talked about the myths as unproductivity. We know that older people are not unproductive, but that was something that was a myth during the 1975, what people thought about aging and their own aging process. Disengagement, that older people are disengaged. I don't think so. Look around the room. I think that that was a myth. It was like, well, they really like to go off and be in a nursing home all by themselves. You think so? I don't think so. All right. Inflexibility, that old people are stuck in their ways. Well, guess what? Young people are stuck in their ways. And if you're stuck in your ways when you're young, you're going to be stuck in your ways when you're old. People become more of who they are, and we know that, and so this is a myth of aging. Senility. Well, it is absolutely true that all of us will have the propensity toward cognitive impairment with very old age, but it is absolutely refutable that senility is normal aging. It's not, and we know that. So this is what Dr. Butler wrote about in his book. Great stats. And I pointed out, because some of you during the course of this presentation might jot down titles that you like, or even read it quick on Amazon, just the blurb. So serenity is another myth. It's not like older people are just like so pleased to sit in a rocking chair on their porch. My grandmother would be the first one to tell you that. And he defined ageism. Bob Butler was the guy who coined the term ageism. So there was racism and there's ageism. And that is, we're going to label you based on what you look like, not who you are, and not what you do. And one of my dear friends, Maddie Mezzi, who's a spectacular geriatric nurse, excellent academician, full professor endowed chair at NYU. One year for New Year's Eve, she decided it was the year 2000, and everybody was worried that the clocks were going to go wrong and everything was going to happen. So Maddie decided she wanted her hair red for New Year's Eve. She has gray hair. She didn't want red. She wanted flaming Crayola cherry red. And she wanted that. So she went to the hairdresser, and the hairdresser gave her this little tinted, like, sort of beigeish oranges, and she said, I said red. She came in the next day, her hair was flaming red. She said they did my hair based on what they thought they knew about me and what they don't know. So we all have those experiences. I'll hear from you about that. The next book I want to talk about is Health and Disease in Old Age, 1982, Jack Rowe, Richard Besdine. Jack was head of the Harvard Division on Aging. I worked for him. He went on to be the president of Mount Sinai Medical Center, and then he was the president of Aetna Insurance, and he's at Columbia now. Richard Besdine is the dean of medicine at Brown. Great guys. I worked with them. And so they wrote a book called Health and Disease in Old Age. Now pay attention to that title, because in this book, what they talked about was the emergence of geriatric medicine to guide healthy aging. And it was very much a disease approach, that book was. And the focus was on symptom management instead of prevention. So once you fall, we're going to do this. Once you can't eat, we're going to do that. And the topics were like urinary incontinence, dementia, infectious disease, and falls. Jack and Richard were profound and sort of like visionary in this book, because there were no books on aging at that time. But they took a disease approach to that. And the NIA was founded in 1976. And for about 10 years, the National Institute on Aging really focused on disease management. Well, the next book that Jack was a part of was called Successful Aging. Have any of you seen this book? It was pretty big deal when it came out, because it's in its second edition. It was funded by the MacArthur Foundation, the ones that do the Genius Awards. And so in this book, the paradigm shift was complete. So that much later, all of a sudden, the paradigm has shifted, and it's called Successful Aging. And this whole new decade focusing on prevention and healthy aging, and the whole idea was the avoidance of disease. That's a good idea. And disability, with the key topics being exercise, enhancing your mental function, relating to others, productivity. And the joke at the bottom says, an interviewer says to a person, well, old timer, about what time would you say what would you say is the death rate around here? And the answer is about 1 per person. So, this book is great. It's got great humor in it. One of the other jokes they say is Max comes in to see his nurse practitioner, and he says, my left knee is killing me. Do you know this one? Okay, so my left knee is killing me. And Max is 95, and he comes in, and he's really concerned about this left knee. And so the nurse says to him, well, Max, you're 95. You're the perfect picture of health. Every now and then, something's going to go wrong. You're 95. And he says, I'm 95, right? She goes, yeah. He says, well, my right knee is 95 also, and it doesn't hurt me. So I want to know why my left knee hurts. And that's true. Don't ever let somebody tell you that it's a sign of old age. It's probably not. If all of a sudden you have something that's changing, that's something to pay attention to. So Successful Aging, really nice book and a nice paradigm shift. Go to 2007. And the next book I want to talk about is Global Health and Global Aging. So all of a sudden, we see people talking, well, so what about America? Let's talk about the whole world. What can we learn from other countries, and what can we teach other countries as well? And so this is the whole notion of global aging trends. And if you've been on our campus, you'll notice that about 1 in 5 of our students is global. They're international, and their parents are coming here, and there's all this wonderful globality going on. So how do we live and learn and understand the notion of global aging trends and the role of the United Nations with 11% of the world population, 700 people, 60 or older? That's really pretty profound, and it's going to increase times 3 by 2050. So that means we really have to be thinking of public policy, understand some of the initiatives like the Clinton Global Initiative, and the role of culture and perception, where the stereotypes that are often used, generally speaking, you'll often hear one about how there's great deference to older individuals in Asia. And if you go to Asia and if you talk to the geriatricians there, you'll find that that's probably a stereotype. And just like any other country, people are people, and they behave individually, not in clumps. So this idea that is global aging is very, very important, and it's important for us to understand it in terms of work trends. Here's an example. So the Philippines exports nurses as a product. Did you know that? They overproduce and export nurses because they know that they create great nurses. And so if you ask yourself, how come there's so many Filipino nurses in my hospital or in my home care setting? It's intentional. They come, they work, they send the money home, and they're supporting their older cohorts in that same way. So that's one example. So global aging. Next, a book by my friend Mark Lax. I met Mark when he was intern. We were both at Yale, and there was a guy named Al Weil. Al Weil was the chief of medicine, and I went down to the emergency room. That's a practice area for me. And he goes, Terry, I got a live wire for you. His name is Mark Lax. We went on to have a great time together. I was studying elder abuse. Mark didn't have a topic. He got a topic, and he's one of the world's leading experts in elder abuse and neglect. But most recently, he wrote a book called Treat Me, Not My Age. Back to Maddie's red hair, aren't we? Treat me, not my age. And that is having this conversation with your caregiver saying, no, right here, this is what I want to do. I want to go parasailing next week. Are you listening to me? And making sure that they are trending with you. So this patient inclusive centeredness, and written for families instead of the professionals. The books I showed you prior were written for professionals. But all of a sudden the shift is forget about them. Get it consumer driven, consumer oriented, so that we can really make sure that you get what you want, find an age-friendly doctor, you get alerts regarding transitions of care. Mark also in this book talks about the perils of hospitals. They're not a good place to be, as many of you know, regarding infection or falls or anything else. And he also talks about warnings about medications and how one maintains control and money in aging, which Jay is going to be talking about after I finish. So very energetic book, very much like Mark, who is energetic and a lot of fun. He's at Cornell in New York, a great friend, and I think that here you see the shift. Now we start disease, and we do healthy aging, and then we do global, and then it's like, wait a minute, let's get it patient-centered. The Macy Foundation, I'm a board member there, is currently shifting everything to patient-centered care, and if you go to Dartmouth, it's called shared decision-making is one of their major thrusts right now. So that book followed by 2012, and this is the Scientific America, Your Aging Brain book. So here is where we start to really think about how do you get science to the public and help your public really understand how they can focus on brain function, reminding people to exercise. Okay, so here's what you're going to do. You're going to exercise, avoid poor nutrition, you're going to avoid alcohol, you're not going to smoke, you're going to make sure that you do a lot of reading, stay engaged, and that you have healthy sleeping patterns, and then you'll be fine. Okay? Can everybody do that for me? All right. Okay, that's what I thought. So all of us try to do these things. All of us are aware of these things. If I were to come in this afternoon and give you a lecture on, well, exercise, I'd like you to do, 5 leg lifts every, and that's not a good conversation. That's not a fun conversation. Here, what I want to say is we know that these are the elements of healthy and successful aging. And certainly as we think about the future, all of us will want to maintain as much healthy brain function. I'm going to be in San Diego next Monday with the Institute on Medicine, and it's called Cognitive Health and Aging. It will be the topic, because this is it. This is what we're thinking about in the next decade. The books will be focused on that. And here you just see some myths about the aging brain, but it just simply lays out some of the things that we used to think about in terms of retirement as terrific, and how early retirement, for example, may increase the risk of death by 51%. That's not a good number, is it? So just things that we are aware of, thinking about, like older people are unhappy. We know that's not true. So the platitudes, and we started with that, didn't we, by talking about Bob Butler's Why Survive and Myths of Aging. So where are the storm clouds? Cost. We've improved our coverage. So Massachusetts was the first state to improve the coverage. But with that coverage comes additional access. Access would mean increase in costs. But here, what I will say again and again and again is, don't talk to me about cost. Talk to me about pricing. And let's see how we can get some of the prices down on some of the things we have. Access. Headlines indicate the government is tackling the rollout issues. Problems are being addressed. And safety. Don Berwick, who's running for governor for the state of Massachusetts, who was the first president of the Institute for Healthcare Improvement, in his 100,000 Lives campaign, and thinking about the way that all of us are thinking of safety and quality in healthcare, with checklists and all the different ways that we think about the trade-offs of care. So some people worry that there'll be rationing of care, but another way to look at that is maybe there'll be less unnecessary care. And that's where you go back to the patient-centered dialogue, where I want, women right now are in a tizzy about, do I get a mammogram or not? Because the press has come out and said that it probably is not going to be life-saving. So that takes very personalized conversations. So where are the rainbows? The rainbows, in my view, are that, we have interprofessional healthcare education at Bouvé and your College of Health Sciences at Northeastern University. Very proud of our faculty, very proud of our graduates, and they're going out and making a difference. Our students work in teams. They're learning about coordinated care, and they're really they have the most advanced training modalities and the beautiful Goldstein Center for Simulation and Activity. Marlene is here today. This was Arnold's dream, and the students are living the dream. So thank you so much, Marlene. Scientific breakthroughs, they continue, and our Bouvé faculty are conducting innovative and creative research in areas that will solve real-world problems. Research projects and awards at Bouvé have increased just dramatically. You can't turn around without hearing that somebody got another award or another grant or had another paper, and we're just tickled about it. Thinking about better understanding of glucose and regulation, family violence interventions, improving diets, drug discovery, compassion, all of that. So very, very exciting work. So on that note, what I'd like to do is just remind you that there's a lot of great progress being made. Healthy aging is all about making sure that we are engaged in the conversation about what's going to be right for us, how to access the colleagues and friends who can help us do that. And what I'd like to do now is say thank you very much for listening. In just a minute, I'm going to introduce Jay. We're glad you're here. Thank you for listening. Thank you.
I'd like to kind of explain my connection to healthy aging. And I went through, as most of us have, the experience with aging parents. And, I think as time goes on, as Terry mentioned, the longevity, it's a situation where we have we have our aging parents, but then we just have a lot going on in our lives. And, so we call it the sandwich generation, where you're really kind of like stuck in the middle. So having gone through that, I was attending a conference in Austin, Texas, where an estates and trust attorney brought in a social worker into his practice, who's a geriatric care manager, to assist clients when that issue comes up. Because I'll be interviewing a client, I'll be hearing all about them, And then, I ask them about their family tree, and I just hear about, sort of all the concerns they have about mom or dad or both, really getting good care, enough attention in the right facility. They're concerned about them being at home, all the issues that really come up from day to day. So I came back to my law firm, and my partner, Bob Russell, God bless him, I come up with my wacky ideas, and he supports me. And we decided to bring in a geriatric care manager into the firm, and that was like our first experience with healthy aging. And then, it grew to 2 and then to 3, and we just a couple of months ago acquired a practice in Newton that, is completely affiliated with the law firm, so that we can really bring that in, as well as a lawyer who just does elder law. So anyway, that's kind of why it's kind of special for me to be here today. So Dean Fulmer told you a lot about, and we all have been reading about so much project in longevity, in healthy aging. So it's created a whole new subset of problems: is how can I afford it? And as individuals are living longer, families are living longer, it seems as an estate planner, the focus is changing. It's not so much on gifting. It's kind of like, how do I take what I have and outlive my money? And estate planning has really taken on a different role. And it's really, the tax laws have changed so that the federal government has a $5 million per person exemption from estate taxes. We still have some state taxes, but for a lot of us, the tax part of it isn't as critical as the financial part of it. So it's kind of really changed the focus of the type of advice that we give to our clients and the kind of guidance that we give. So, a major part of healthy aging is making sure that the money lasts and that it's used wisely. And so one part is really taking control over the property that you've owned, your hard-earned savings, your retirement accounts, and really looking at it in the context of what I need versus what I can comfortably get to my family. Then there's the capacity issues, control over your health care in the event that you at some point lose your capacity to make financial decisions for yourself. And then there's the sort of the traditional estate planning, which is, how do I minimize or eliminate the costly expenses associated with probating an estate, estate taxes when they're applicable, and all of the other costs associated with health care, independent living, assisted living, nursing homes, and et cetera. So, which button do I push? I'm gonna try this. Okay, got it. So this slide just has, most of you are probably familiar with the essential estate planning documents, and I'm just going to spend a minute on this. And it's very important in connection with healthy aging to make sure that your documents are in order, because frankly, you just never know when capacity no longer allows you to change these documents. So, one of the things to do is, if you haven't updated an estate plan, make sure it's updated and make sure it's reflecting your wishes. You see here a list of the key documents. We have your will, trusts. Wills and trusts work together. They're kind of a team. The will typically provides for the disposition of your tangible personal property. That's all of your household items, furniture, furnishings, jewelry, etc. You appoint an executor, now called a personal representative in Massachusetts, to wind up your affairs. And then we try to put the emphasis on the trust and not on the will after that. And the reason for that is that the trust is private. The will is a public document. You're required to list all of the assets that's available to everybody in the courthouse. You pay fees to attorneys and to the court to file documents. And whereas the trust is private. And the trust also allows you to provide asset protection and tax savings to children and grandchildren, which you can't get through, just a simple will. Then we have the documents that deal with capacity issues. So there's a durable power of attorney where you appoint an agent to make financial decisions for you if you're unable to do so for yourself, which is an extremely important decision. Healthcare proxy, who makes healthcare decisions for you if you're unable to do that yourself. We now routinely do HIPAA releases, which are forms that allow loved ones to get at your medical records regardless of capacity. Living wills, which is a statement of your wishes that, that if you don't wish to be kept alive on life support equipment, it's made very clear to your healthcare agent and your other loved ones. And also making sure that you update your beneficiary designation forms because, sometimes those forms were done a long time ago, and it's very important that they name the right person or a trust or, however it should be done. So I'm going to get to the heart of it, which is dealing with the costs of long-term care and, the stress and fear associated with the loss of independence that comes with aging. The question is how do I deal with these costs? And as Dean Fulmer mentioned, the longevity, the other thing that is really increasing are the costs. So just a few quick statistics. Nursing homes are now costing between $132,000 and $180,000 a year. Assisted living between $60,000 and $85,000 a year. And that could be much higher if you bring in more help, into independent living communities. Some of them require very significant deposits. They're very expensive. The good news is there's more and more choices coming up of types of independent and assisted living communities that feel more like home. And then there's staying at home. And we recently had an analysis done for a couple, they're a high net worth couple that live in one of those beautiful homes on Jerusalem Road in Cohasset. And, when the analysis was done, it was clear that they should move to an assisted living community. Both are in their 90s, and the wife just had a minor stroke. They're actually still doing pretty well, but they wanted to stay at home, so the family just spent the money that it took to make the home safe, bring in extra services, and make home continue to feel like home. So in terms of planning for the costs, with higher net worth individuals, self-funding is always always an option, but you really need to take the time to work with your accountant, financial advisor, to take a look at the spend down rate and make sure that the money's being invested in a way to help you pay for the costs, and also to make sure that you're not through, for example, estate planning techniques, giving away money that you really are going to need. And then there's insurance, and that's really changed. About 15 years ago, long-term care policies were a reasonable approach in the sense that they were more affordable, and you got more for the money. The insurance companies, because they were being used so much, have really jacked up the prices, and a lot of insurance companies have got out of the business. There is an option that you can look at that's becoming more popular that life insurance companies are offering. So, for example, there's one product, for example, called the MoneyGuard product, where you pay one lump sum. I think it's something shy of $100,000 right now to get you the right amount of coverage. And you pay it once. You can request your initial payment back at any time, whereas the insurance company will get the appreciation. And if it's not used for long-term care, it becomes a death benefit for the family. So it's not a use or lose proposition. And then there are life insurance policies that have riders attached to them for long-term health care. So, sometimes a client will come in and they'll say, gee, I don't really need this life insurance anymore. It's very expensive. We'll take a look. We'll have an insurance agent. We don't sell insurance. Take a look at the cash value and see if it could be converted possibly into one of those kind of policies. So that option is still out there, and it's just a cost-benefit analysis, and you have to be careful that that it is a good financial deal. Then we have our Medicare system, and just a couple of tidbits about the Medicare system is that we all know that it provides health insurance for all Americans that are age 65 or older. And however, for long-term benefits, it's very limited. So basically, you get up to 100 days in a skilled nursing facility, as long as it's within 30 days of a hospital stay, and the hospital stay has to have lasted for at least 3 days. So we had a case in our office where, it was actually a combination where we used the geriatric care manager. And I have a longstanding client who lives in a beautiful Tudor off of Commonwealth Avenue in Newton. And she had lost her, she's in her mid-80s, she had lost her 60-something-year-old daughter to cancer. And that threw her into a tailspin. She went into a depression, and she started becoming very sick, couldn't hold food down, and they couldn't figure out what was wrong with her, so they said, you really need a psychiatrist to work with you. And she ended up at home with AIDS 24 hours. So I went over there one day with my geriatric care manager, and I was shocked at how much weight she had lost. The aide was sitting in the other room, and the aide was pampering her. It was really, in my opinion, aiding her death. So our geriatric care manager said to her, "We got to get you in the hospital today." She called up her primary physician, said she needs to be admitted for 3 days so she could go into rehab. In rehab, so she drove her to Brigham and Women's Hospital. She went into the hospital for the 3 days. She went into the Newbridge facility for rehab. And 2 months later, she was almost like brand new. They just brought her back to life. And, so it's, it's really, the system itself, understanding the system is really a very big factor. So along with Medicare, a lot of people also get so-called Medigap policies. And there are professionals out there we have on our staff, an RN, who just specializes in helping clients understand Medicare and understand Medigap policies. And she doesn't get involved at all in selling or receiving any referral fees or commissions for insurance, so it's a very objective service. And then we have Medicaid, and you're probably, again, familiar from other talks about how the Medicaid system works, so I'm not going to go into too much detail. But, the Medicaid system is designed to provide coverage for nursing home coverage, so it doesn't provide much at all for assisted living or independent living, but it's designed to provide nursing home coverage for people who are in essence destitute. You can't have more than $2,000 of assets, and and there's a 5-year look-back period for gifts that are made in order to qualify. So there is a lot of planning that can be done where people can be qualified for Medicaid. But first of all, the important thing to realize is that because it's nursing home-based, most of us, and I'll speak for myself, really don't want to go to a nursing home. We really would rather live as independently as long as possible. Most of us want to stay in our homes as long as possible. And then, assisted living is the best option as opposed to a nursing home, which is more of a, more of a sort of a typical hospital setting. So so the Medicaid system is not really, it does provide a little bit of coverage, but really very little coverage for assisted living. Medicaid planning is still a very popular area. I mean, a lot of families, they need to qualify. And in doing so, there are ways to qualify that you can still protect some assets. For example, your principal home is still a non-countable asset as long as the equity is below $814,000. Things like your personal belongings, jewelry, furniture, appliances, things like burial plots, and there's special rules for joint bank accounts that need to be considered in those situations. The gifts that are made disqualify the applicant for receiving Medicaid. I mentioned the 5-year rule, and also when you make gifts, basically the way they do it is they look at it as you're disqualified at the value of $300 a day, or approximately $9,000 a month. That's a number that changes, and it's by state. So that's the Massachusetts rate. There are exceptions for gifts to spouses, disabled children, and there's something called a pooled trust where you can gift to a trust where the money can be used to enhance the care, but eventually it will be used to repay the government money that's paid on your behalf. But we have a client just comes to mind who we use that pool trust to provide her with a lot of additional services. So that's another good way to do that. The state also has this structure where they can apply a lien on property to get paid after the death occurs. However, it applies to probate property, so there are ways to avoid the lien by keeping the property from becoming a probate property through jointly held assets, life estates, and trusts. So there is quite a bit of planning that gets done. So the kind of things you can do is when you're looking to qualify a person for Medicaid is spending down the money, and some of the ways to spend it down, for example, are making improvements or repairs to the home because the home's a non-countable asset, buying things for the home because the furniture doesn't count. You can even buy a new car even though the person's not driving because that doesn't count. And things like medical expenses, prepaying funerals. There are also Medicaid annuities, which are designed so that you can get some of the money, shift the money over to family members. Certain types of trusts, like income-only trusts, you lose the income, but the principal can be preserved. And things like I mentioned, like life estate or use and occupancy agreements for property are ways to spend down the money, but not have it go to the government. And there's a lot more to that. So it really comes down to, when it comes down to home care versus the nursing home, as I mentioned earlier, the trend is really to, and I think it's just going to really expand with the baby boomer generation, to stay at home, enhance the journey. It's all about quality of long-term care. And as Dean Fulmer mentioned, I think we're all going to see apps and devices, things that you'll use on a tablet that will, make the ride much more pleasant and meaningful. So as I mentioned, one of the things that families can do is they can retain the services of a geriatric care manager. Call that the coach. And what the coach will do is will guide the family through the process. They're insiders, so they will really help the family get quality care, and help the family advocate for the elder to get the best medical care. I love the book saying that, really, you really need to treat me, and not just say it's because I'm 90 years old. And these people help evaluate mental and physical capacity. They coordinate home care. They help select housing options, and work with us attorneys to review the legal and financial needs. So if anybody has any questions, please feel free to call me at any time, and very much thank you for joining us today.